Well, good afternoon and welcome, everyone. It's a pleasure to see so many of you in Lecture Theatre 2 at the John Radcliffe, and also a warm welcome to those of you joining online. My name is Keith Channon. I'm the Director of Oxford Academic Health Partners, a long-standing supporter of the Joint Research Office, former Director of R&D for Oxford University Hospital. So it's a real pleasure to be here and to be chairing today's Joint Research Office seminar, which is on this critical topic of how we manage our clinical data for the purposes of research. So this is very much focusing on the Thames Valley and Surrey secure data environment, the SDE, and very practically speaking, what does it mean for us? What does it mean for me as an individual researcher? And we've got 2 expert speakers and 3 expert panel members, so 5 colleagues to help us answer this question and get real value out of this seminar. Housekeeping points very briefly. We are going to record this session. There are no fire alarms planned. Please attend to the presenter. And the questions, we're going to have 2 presentations first. Then we're going to have a panel discussion. And the questions which we'd like you to submit need to be done via Mentimeter, which I'm sure many of you have used before. But this is the Mentimeter page. You go to menti.com, you enter the code shown on the slide, and that gets you onto the Joint Research Office seminar page, and you can then type in your questions. There are already 10 or 15 questions on there, so you better get going as soon as you think of any, otherwise you'll be behind in the queue. So I'm going to introduce, first of all, our 2 speakers, which are Kerrie Woods and Jim Davies, who are going to go in that order, I think, and give us a brief presentation each. They're both experts in the governance, operational management, and value of secure data for the purposes of medical research. Both of them have been instrumental to Oxford's activity in this space and have had nationally leading roles over a few years, shall we say. Yeah, a few years, including roles in government, Department of Health, and across many other centres in the UK. So there's no better speakers for us to hear from. I'm grateful to both of you for being willing to speak. On my left, you may not see them on camera yet, but you will when we have questions, are our expert panel. We've got Ben Atwood representing Oxford University Hospitals, Brian Marsden for the University of Oxford Medical Sciences Division, and Tanya Smith from Oxford Health. So we've got really good representation from across the Oxford partners. And again, we're grateful to you for being willing to subject yourself to questions from the audience and online, and we'll come to you shortly. So with that, I'd like to hand over, if I may, to Kerrie as our first speaker. And then I won't come back on the platform. Jim, you're going to take over straight after that. And then you're going to stay panel, you're going to stay sat on the platform, and we'll come to you with questions and try and engender a really nice discussion when we've heard the talks. Thank you.
So much, Keith. So we were going to be a triple act today, and we are a double act because one of us is a little bit poorly. So I'll come back on at the end and talk a little bit about some of the commercial activities and work that we're undertaking to enable access to data. But essentially, I am the Programme Director for the Thames Valley and Surrey Secure Data Environment. I also look after a lot of R&D clinical informatics in Oxford University Hospitals. And I lead the National Information Governance and Ethics Working Group for a national network of secure data environments that we'll speak about later on. Let me see if I can work these slides that way. Amazing. So I want to start off with a little bit of policy context, a little bit of background about the programme, and then I will talk very briefly about how we're doing. I'm going to hand over to Jim, who's our Chief Technology Officer, and he will talk a little bit more in depth about the infrastructure that we've built. In terms of our mandates, this is the policy paper that's kicked it all off. So Data Saves Lives came out in 2022. Essentially mandates, with a few exceptions, the use of secure data environments in order for researchers and policy analysts to access routinely collected NHS data. There are a few exceptions to this. One of them will probably be consent. So clinical trialists in the room who are panicking, please don't panic. And the cut over to this is going to be done very much in line with the research community. So it's not something that's going to happen and be done to people without their agreement or consent. But the idea here is that we will establish a large number of benefits, both in terms of engendering patient confidence, accelerating access to better quality data sets to support research, and also improve the quality of data for research, but perhaps even more importantly, to improve the quality of data that's available for care in the hospital. So we're really excited about the idea of a secure data environment. What are SDEs? Well, they are essentially secure platforms through which we are facilitating access to data. Researchers can come to that data, they can undertake their analysis, but the raw data never leaves. I mentioned earlier, we're part of a secure data environment network. This is a national network funded by NHS England, Department of Health, NIHR, DSITs. It's one of those programs that's got funding from lots of different places. And it is essentially addressing the needs of health data users by creating a national federated network. So as you can imagine, we're looking at a 57 million population scale here. We have full coverage of rich multimodal data plans. So that is not just a lot of the structured coded data that many of us see every day when we work with NHS data, but a lot of the information that's really rich and valuable for researchers is sat in free text. It can be very hard to get hold of and access and make use of, particularly from an AI and machine learning perspective. We're also thinking about diagnostic imaging, digital pathology, and some of the omics, the whole genomes data that many of us will be aware of as well. And a lot of this is underpinned by a really robust patient and public involvement and engagement programme of work that is happening both nationally and also within each of the local secure data environments. In terms of our SDE, we're smaller than some. We've got a population of about 4.3 million. And the plan here is that we will pull data from primary care, secondary care, acute mental health, community, and ambulance services. And we have the governance to be able to pull that data in an identifiable form and to be able to link it deterministically. As Keith mentioned, we've worked for a very long time together, being able to get this data used and linked together. It is an absolute boon to be able to link it using identifiers rather than relying on data that's pseudonymized at source. We know that that's incredibly important for a lot of our academic and commercial stakeholders to know that they can rely on the data. We as an SDE are doing very well, possibly arguably the best SDE in the network, but I would say that, wouldn't I? We have received the highest funding per capita in terms of public sector funding that we received. Our design was complemented as setting the bar. Many of the approaches that we've taken for governance and metadata management in particular are now essentially dictating the way in which the network is operating moving forwards. Our programme has a particular focus on cancer and diagnostic imaging. In terms of how we're doing, a little bit here around, I want to talk about achievements and enablers. So I mentioned earlier on, we have prosecuted a first of type approval, a section 251 approval to be able to access identifiable information and pull that in. I know it sounds a bit daft, but you can't do that in the NHS for research purposes without breaching the common law. So we worked incredibly hard with an awfully large number of policy stakeholders to get that in place. We were the first SDE to do it. We have shared a lot of that with the rest of the NHS network. I think we're now at 8 or 9 SDEs that have a similar section 251. Alongside that, we've got delegated ethics. So for researchers who are undertaking non-interventional activity, they're able to come in and make use of our ethics. It saves them time, saves them money. We're currently working for standard projects, which are non-interventional, a single application form and a single contract that they would sign. We have managed to get the HRA to agree that researchers would not require additional HRA approval or IRS. So we're in a really nice position there. We're trying to reduce the amount of unnecessary bureaucracy that exists for researchers, because it's not only very irritating and expensive for researchers, but also for those of us who are providing these data services. We've agreed a joint controllership model with our NHS partners in the region. Again, that is quite a new and novel approach. It is a template that we're now being asked to share across the broader network. That allows us to pull in data on a regular basis. So we're not having to go to the various trusts and controllers within our SDE organisation and ask them on a project by project basis for the data. We pull that data in, we hold it there, it is persisted, and then we're able to publish extracts of that data for approved research purposes, which again, from the perspective of being able to move quickly on this, is a bit of a game changer. And we have an agreed value assessment framework. So there is a sense that where there is downstream commercial value that's created from the various research activities, that the NHS shares in that. And we know from engagement with our patients and public that that's really, really important to them. We have a data access committee. Our data access committee is called the SARC, the Services and Access Review Committee. It's got 30% lay members on it. It has experts from a health perspective as well as from a data perspective. They are working at the moment to develop approaches to be able to approve data requests as quickly as possible. So at the moment, we're just working on understanding exactly how little information they require in order to move through, rather than the situation that we often see with DACs where they are essentially swamped with information, research protocols that they don't necessarily have the capability always to be able to look at and review without expert support. So it's really about trying to move that through as quickly as we can, but making sure that that process remains robust and that our SARC is able to essentially determine the desirability of any research that's coming through. A lot of that is based on the workings of a community of practice that we've created with patients, public and healthcare professionals who are supporting us with a lot of our policy development. And finally, we have built a number of tools that will support automation and researcher self-service. Jim can talk to these perhaps a little bit better than me, but essentially we have a tool that's going to support researchers to be able to discover a lot of the data sets that we hold. So a metadata discovery tool, some of you may be aware of it, it's called Mauro. We are also developing a user portal, so this will essentially automate access requests for researchers. They will be able to integrate that with a Mauro query. So if you go on, you have a look through the metadata, you can essentially build the query for the data points that you want, and you can port that automatically into your application form, which again will flow straight across to my SARC committee for review and sign off. And we also have a back office tool, which doesn't sound that exciting, but actually is terribly important for us. We spend an awful lot of time, I can see Teresa there, undertaking management reporting. This really helps us to be much more accurate about the costings and the timings for researchers, how long it will take for us to be able to pull the data extract that they require for them once it is approved. Just done that one. There we go. And then just to give you a sense that this is not vaporware side, we are ingesting data into the SDE as it stands right now. We have 30 billion rows of data ingested. That's last week's figures. It's probably more now, from around 25 source systems. As I mentioned, we have a large focus on cancer. So a lot of this is the cancer systems that we've looked to pull together so that we can create a cancer specific data mart, which we're really excited about. We think it will be the first of type in the country. We have, in terms of our research-ready data, about 5.7 billion rows have flowed through into that so far, into what we call our gold layer, and Jim can talk to that later on. That comprises about 11 million unique patient records, although I should say they are not necessarily complete records. We have to go through those and have a little look at them and understand quite what exists there. We have just onboarded Royal Berkshire and Milton Keynes data, so alongside OUH, a lot of the focus now is going to move on onboarding the acute within the region. And I'm pleased to say last week we successfully connected to Oxford Health as well. So we'll be bringing, where's Tanya go? There she is. We'll be bringing in the mental health data really soon, which we're really excited about. And then finally, it just gives you a little bit of a comparison of where we sit in relation to the other secure data environments across the network. The SDE among the regional secure data environments has the largest pipeline of any of the subnationals. And these figures are a little bit out of date. I think we're on about 160 projects now, but this is 136. We essentially are responsible for over a quarter of the projects across the regional network, just our SDE, which is very exciting and is up from about 20% in October last year. So I will leave you with that. And Jim is now going to do a little bit of a deep dive for you into the architecture.
Although I promise not too deep. So what's in secure data environments? Some people have also used the term trusted research environment. This can mean different things to different people. What's important about ours is that the kind of research we want to support, we focused on, is clinical and translational research more than simply observational. Nothing wrong with observational research, but there's a lot of research that goes on using national data sets, just the diagnostic codes and procedure codes and some episodic data. That is fantastic. Really informs policy. There's some lovely stuff came out of COVID on that as well. But that's not really where we see the role of regional secure data environments. We should be getting into the detail, and we should be interested in the way that the data looks in the clinic, how it's used, where's the context, how do you inform transformation? So what does this mean? Well, we don't just have a trusted research environment where somebody else would prepare the data set and it gets sent over to us, and we airlock it in and other people can be allowed access to it. That's almost a commodity. That's just a properly managed Azure instance. And you'll find that there are commercial organizations that provide that. For example, for CRUK, they have a trusted research environment. That's all very well. What we're really interested in is that how do you get the routinely collected data, which is collected against, if you like, care concepts. The data representation in care is not, to the first approximation, research ready for all sorts of reasons. In many clinical systems, it's being collected against proprietary schemas and representations that are sometimes hard to decode. I mean, you sometimes have to read the supplier's documentation. In some cases, and this doesn't apply to OUH, but those representations themselves are confidential. So the current situation with Epic, I don't know if we're not going to have any Epic loyalists here, hopefully, but the actual way in which the data looks inside the system and the screen designs and the form designs, if you were to take the contract that an NHS trust would sign with Epic, you can't share those. Now, I think there's going to be some flexibility around this going forward. But that's a problem. Now, why is it a problem? Because the way in which high-value research happens at the moment is actually through direct engagement with the clinical setting and the clinical systems. People will work directly into think about a clinical trial. You have research nurses or CRO or people who will be interpreting the care record with first-hand engagement, with direct engagement with the clinical setting, and they'll do the quality assurance. They'll gather the context. Is this the biopsy that's related to that imaging? Has the patient, let's have a look. Do they really have this comorbidity or not? Was that a confirmed diagnosis? Was it all of that sort of stuff? That has been done by hand, which doesn't scale terribly well. That's why clinical trials can be so expensive. But that's been done by hand, and it's been done by the researchers. What we're trying to do is to say we will provide the data at quality for research without you having to send somebody to log on to the EPR with the appropriate governance and authority. That means we've got to provide that assurance. So one part of our SDE is a data warehousing operation, but that has to be reproducible, transparent. Everything has to be understood. Anything we do to the data after we pull it out of ARIA, InfoFlex, Cerner, Solus, any of the other systems, anything we get, we have to preserve the context so that we can actually make it available to the researchers so they know what they're dealing with. They can assure themselves. One of our clinical trials colleagues, a guy called Michael Lay, said, first rule of clinical trials is never trust a derived field. Well, okay, we have to do that. We have to have some derivations, but we have to share exactly what they are, and they have to be auditable and inspected by researchers. So the data warehouse is an industry standard medallion architecture. We'll talk about that in a second. I know we want to move on to the high value panel conversations, but it's industry standard. That's what's important. And we get the raw data in. This, as Kerrie said, took a lot of debate, but we had to make the point that we do not, much as we love our colleagues at Royal Berkshire, we don't want to ask them to de-identify and process and standardize all of the data before sending it to us. Because then they have to actually build an infrastructure that mirrors what we've got, and they need to maintain it and keep it secure. No, send us the raw data. That's the warehouse side. The research environment, well, that's exactly what you'd expect. Project-specific workspaces, so virtual machines, collections of virtual machines, data sets that are made available. Research groups have shared data set, and they work on it. And the first rule has to be whatever tools they would expect to use on their existing computing infrastructure we have to make available. Otherwise, this doesn't work. And that's a big challenge. I'm shout out to Dan McGowan back there. A big challenge when it comes to imaging. So we're working on that one. And an airlock mechanism for user data export. But the other thing I would like to say before I briefly discuss these diagrams and hand over back to Kerrie is that the whole point of this kind of secure data environment, it's an eyes-on. So we don't try and communicate everything about the data and everything about what could be in the next column. Actually, no, you can see the data. You don't see the identifiers. We've removed those, but you can see the data, which means, of course, we trust you. This is an environment for researchers that you can trust. People who work for an organization that backs them, has vouched for them. If you can't trust somebody, then you shouldn't be giving them a log on to see patient level data. You should push them towards Ben Goldacre's manually hand-cranked open safely solution, where actually you take some synthetic data, you design a query, you'll send a query off to the people who run the system, and they'll send you the answer back once they've checked it over for you. This is, no, we've got, I mean, there are more than, JRO in the house, they can tell us how many projects are currently running in OUH alone. If you're going to try and support that strength and depth of research, this has to be as shared and as involved and as self-service as possible. So data warehouse, it looks like that. There's bronze, raw data comes in, we keep a copy. We standardize it, but not in a lossy, crazy sort of way. It's just if that column's supposed to have NHS numbers in, we'll make sure it's got NHS numbers in. If that column's supposed to be a dosage or some medicines administration data, it's there. It's not that additional bonus note about how the patient's sister is going to come in later to pick it up and here's her mobile number. Which is exceptional, but does turn up and upsets people if you actually let it through. National data opt-outs applied, of course. There's a facility that we can actually work with clinicians to provide additional insights that go with the data so you know what you're dealing with. You can assess over on the researcher side whether it's fit for purpose. A de-identified version of the data is made available. One thing Kerrie mentioned, this has to be catalogued. We have to capture everything we do to the data, and when the researchers want to know, where did this come from? What did you do to it? What can you tell us about the context? What power form was this entered into in Cerner? What were the other questions? What were the options that whoever was completing this form could choose from? That has to be made available, and it has to be made available automatically. The research environment, just coming back to the fact that we have to trust the researchers, the airlock process should be fairly streamlined and straightforward. It's just a check, make sure that you're not taking the wrong thing out. Anything people want to bring in, we should facilitate that because we're already working with people we trust. It's that kind of secure data environment. And again, there's a catalog. All that goes together. That's what we're building. It's what we've built. It's operational. We'll continue to develop it over the coming months. One thing about Gold, what sort of data do we present? Well, the first thing is a de-identified version of what it looks like in Cerner. Because if you were trying to build some intervention, some algorithm, some tooling that would go into the clinic, you need to know what the data looks like on the ground, not some processed version thereof. If something isn't captured, and of course, this is also what you need for improving data quality and reflecting upon practice. What does it really look like when that power form is filled in? Now, I know we've moved off Cerner and maternity, but when that power form is completed in OUH, is the data that's needed to fill in answer those questions available, or has it come in the wrong point in the workflow? You need to be able to get into that level of detail for some use cases. That's Gold A. Gold B is the future idealized standard shared care record, the standardized record across the NHS that will have been developed a few years after the National Programme investment, but nevertheless will be coming at some point. We push Gold B to one side, but it's imagine you had all the data in Fire and it was ready to go to a bunch of tooling. That would be great. Gold C, we are doing in collaboration with the users, because this is moving from the clinical concepts to the research concepts. So a nice example might be in cancer, date of diagnosis. There isn't a column that has date of diagnosis for a cancer, for a patient journey along a care pathway in cancer. They just, that's derived concept from data pathology reports, but also MDT meetings and so on. But it would be useful to have that if you're part of the cancer research community, you would like to have these concepts together with their known derivation upfront. So we're building that, but we're building that hand in hand with the researchers, and that will be an ongoing process. If somebody needs a different model, they can have a different model. Back to Kerrie, who is also Fred.
Time's marching on, and also I do a terrible impression of being Fred, so I just want to flash up one slide here, because I'm sure this is what you're all thinking, right? Oh my god, this sounds amazing. How do I access this brilliant data? So as previously mentioned, we have to cover our costs. We have a Department of Health and Social Care mandate to do so. There's also a mandate from the Department of Health and Social Care and our patients and public to make sure that the NHS is getting fair value for the data assets that it holds and that it provides. So with that in mind, we've got a burgeoning service that Fred is looking after. I think Fred would rather this wasn't just his personal email address, but at the moment, this is pretty much how it stands. And I can give you his mobile number and his home address if you require it afterwards. So yeah, if you're after data, get in touch with us. We can talk to you a little bit about whether we can do it. We are onboarding data. We will be onboarding data for years because it is immense, because the job never really stops, like painting the fourth bridge. But we can let you know when we're likely to have it. We can give you a little bit of a sense of the costing of that, even if you're looking at just applying for grants at the moment. We have a lot of people who are working with us just to understand what the cost might look like to stick in their grant applications. We also have a number of templated projects that templated contracts that we're working on, so we can share a lot of that with you. A lot of this is about being transparent, giving you a sense of what that feels like up front. And as Fred's put on here, there's quite a lot of work going on that will come live in the next 6 months or so, which is really around trying to develop and implement these tools so that a lot of this workflow becomes a lot simpler and a lot more, as Jim said, automated, self-service in the future, saving us all time and money. And I will leave it there. Thank you very much indeed. Going that way, yeah.
Great. Thank you very much indeed to Kerrie and to Jim for those fantastic updates. Perhaps if I could have some help getting the slide up that shows the Mentimeter code whilst I'm just moving on. We also have, as well as our two speakers on the stage, I don't know whether those of you online can see the panel yet, but you'll see that we've magically increased the panel size as well, because we now pleased to welcome Sian Rees from Health Innovation, Oxford and Thames Valley. Thank you particularly, Sian, for putting it back from London in time to join the panel discussion. So on your screen, you should now see the Mentimeter page URL and the reference number, and you can type your questions in. I'm going to come and sit down closer to the panel because I think we can then all be seen in the same feed. I've introduced the panel just by name, but I think the audience would find it really helpful not just to know who you are by name, but to hear a little bit about what each of you does, and perhaps a perspective, therefore, on what is your involvement with and engagement with the SDE. So we can start, Sian, at this end if you want, from your particular perspective. Just say what your role is, and to give people a flavour of how that means you work with data and specifically with the SDE.
Okay, that's fine. So hi, I'm Sian. I'm Director of Community Involvement and Workforce Innovation at the what was the Academic Health Science Network and is now the Health Innovation Network across Bob and Frimley, basically. My background, I'm a public health medic by background, and my current involvement with data is that I have been working with the shared care record locally for the last, since its inception, really, since 8 years, and with the secure data environment team to bring the perspective of patients and the public and professionals into the design and delivery of the programmes, essentially running workshops, looking at what people think is important that we address, and helping the team do that, I suppose.
Great. Well, it's great to hear from you first, because it reminds us all that the patient perspective is behind all of this. So thank you. Ben, you're representing, if you like, the host organisation, the NHS Trust. Do you want to tell us a bit about your role and what the implications are?
Thanks, Keith. So I'm Ben Atwood. I'm the Chief Digital and Information Officer for OUH and the Senior Responsible Owner for the Thames Valley and Surrey SDE. So as people keep reminding me, I'm the one that goes to jail. Yes, if we breach things sufficiently. I should also say I'm a consultant in intensive care and anaesthetics as well. So I think have some perspective on the value for clinicians delivering care, but also hopefully the link between research, really high quality care, and the insights that the SDE provides. So I think the real unusual, or at least novel aspect that the SDE provides is it improves data quality. So there's a virtuous circle where data that flows in, as Jim and Kerrie have eloquently described, we've not really ever had to mark that homework as large organisations or even small healthcare organisations. So doing that and then being able to reflect that data quality or the lack thereof back into the context of delivering care is an extraordinary opportunity, and one that is actually much needed. And it can be as informative and impactful as research. It is research. It's a form of research. The second is recognising the value of the data. And I think it's something that the NHS and organisations inside the NHS has really struggled with for a long time. And the third thing is, being brutal, there is a commercialisation aspect to this. For a long time, we've worked as healthcare organisations with commercial partners, with academic partners, but actually having a single point of entry, or at least a sort of an understanding and a proper framework for how that happens is critical as we're going into an information era which is quite unprecedented and is going to become increasingly valuable. So I think I'll probably stop there.
Great. Thanks, Ben. Tanya, you're, I guess, representing one of the partner trusts of Oxford Health.
Yeah.
Really important for you. Slightly different data set that you might be interested in. Tell us about your role so people know what you do, and just perhaps a little comment about your perspective from Oxford Health's point of view.
Absolutely. So I'm Tanya Smith, and my role is a dual role at the moment. So I'm on secondment at the moment from Oxford Health to Oxford University Hospitals for the SDE programme. And my background, my role at Oxford Health was the head of research informatics and the deputy head of R&D, and that has been really pivotal in me supporting this project being on secondment, and supporting from my role as in information governance and data governance around research governance elements of this project. And equally my knowledge of the clinical systems to support research. And that's really important. My background is more in mental health data. So that's been really pivotal in supporting the SDE team in starting to look at the mental health side of the data sets and the importance of that in supporting the SDE, and looking at all the other data sets that support that in the acute space, as well as the imaging space. And the network that I have with the researchers that I had with the Oxford Health BRC. So, yeah.
Great. Thank you very much for that, Tanya. So, Brian, you're representing Medical Sciences Division of the University of Oxford. I guess the university would be seen as the people who perhaps want to use the research data most actively for that purpose. How does the SDE, what's your role in the Medical Sciences Division, and how do you interact, or how do you see yourself and the university interacting with the SDE?
Yeah, and so I'm Associate Head of the Medical Sciences Division for Digital Information, so anything to do with data or IT is my problem. But that also includes how we as researchers, and I'm a researcher, I'm a consumer of this data, how we interact with our local SDE, as we're talking about today, and how we make sure that our colleagues, our researchers, are provided a service that is as good as, if not better than, what they have at the moment. There's no doubt that this change in the way that we as researchers access data it really is a big change, and it's going to massively impact the way that we as researchers have worked over the years. We've really got to rethink the way we do things. And I think there is a very clear opportunity to co-create a workable SDE with the team who you've heard from today to get something that really will work really well for us. Perhaps not in all cases. There will be some particular data types and particular research questions that may not work well. But we are looking at ways in which to support that within the university going forward. So I see a very rosy future here, something we can do together, opportunities to access data that we didn't know existed before, high quality data, as Ben says, the quality of data is only going to improve. Lots of positivity, I think.
Great. Thank you very much for those introductions and some general comments. So please continue to submit your questions on the Mentimeter panel. We've got a few here, and I'm trying to triage these in real time. There's quite a lot panel that we need to try and get through. So I'll try and feed them to the right people. Please, if you've got an additional comment, put your hand up on the panel because we want to hear from all of you, and try and keep it fairly brief. The first one, Ben, I might just come to you for some clarification. What's the scope of the SDE currently? Because we've got everything from social care to hospital. What data, and yet Jim, you've told us we're focusing on cancer and diabetes and some. So what's in, what's not in, and how's it going to evolve?
Well, I'll look to my esteemed colleagues for where we are with current progress, but I think conceptually we're looking for all care providers are open to participate in data input, because clearly not only the quality but also the quantity of data and the sources that are coming in all contribute towards being able to then extract that information in a systematic way, then to be able to deliver the research questions that are being asked of that. So obviously acute care providers, community, primary care, social care at some stage. We are still in discussions with partners about how that will work. And as you'd probably imagine, because we are going around each of these stakeholders and actually largely through Sean and through the PPIE work to effectively establish those trusted routes, getting these stakeholders on board. So I think there's scope in principle versus scope in practice. And actually, Sean, you might just want to answer how we've kind of managed to get as many people as we have on board, because actually that's been quite a success story, I think.
So we've taken the view that the way in which we ought to approach involving people is a proper co-production approach. So it's not just sort of having the occasional focus group with a bunch of patients because we're dealing with cancer. It's saying actually we want to have a very broad group of patients, public and professionals in the room to have a debate about certain aspects of what we're doing. So over the last 18 months, we've held 6 workshops and we've addressed things like opt-out. So as you know, there's a national opt-out at the moment. The CAG approval that we got means that we should have a local opt-out as well. So we've had that discussion with people, and we'll feed that back not just to the local team, but also to the national team, because there's a lot of national work looking at all aspects of public deliberation and the way in which data is handled more broadly. We've also run workshops on trust, on choice and value, and those things will be directly related to what happens to the data access approvals process and the policies that we put together. So I think the success is to make this open and easy for people to take part in. We are also super aware that there's some people that we will not talk to like this. And so we're running some particular work with seldom heard groups, or often called seldom heard or marginalised people who would not perhaps come to the sorts of workshops we're running. So we're doing some work with Gypsy Roma travellers, refugees and homeless people on the grounds that there isn't much published about their particular views around data and how it ought to be used. I'm not saying that it'll necessarily be different, but they're populations who have perfectly reasonable reasons for feeling disenfranchised by the system, and that includes research. So it's an ongoing, the idea is this is an ongoing process. It's not something that stops and finishes. You know, you don't just run the focus group and say we've sorted this. You have to keep engaging people.
Yeah, thank you for those comments. On the topic of sort of scope, Tanya, can I just ask you for a comment? Because I mentioned mental health, and clearly that's, even though you're currently seconded out of Oxford Health, that's very much that's a complex and different set of data presumably a lot more focus on the need to be able to process natural language rather than just data fields. And even, dare I say, patient-reported outcome measures that I know clinically you use a lot. So without wanting to run before we walk, how do you see those challenges, and how is the SDE already looking to incorporate the richness of data that comes from mental health care?
Yeah, so one of the key elements of when I started was to look at previous experience of the data that we worked with across various clinical data sets, and what we ideally needed to support use cases, including the use cases that we struggled to support because we didn't have access to the multiple data sets. And equally, elements of the data that is in free text, as you mentioned, and I've previously worked at Oxford Health with a number of really good data scientists that structure the data through various different models. And I've been working with Jim and team, and we have a focus at the moment looking at how we can do that within the SDE, not only for mental health. There are other data sets that also required structured pretext, and looking at some ideal concepts that we might think about doing going forward. What I would say as well is, though, the beauty of the SDE is that we really need to consider, once we get the multiple data sets that we will have to support mental health as well as any other disease set, that could negate the need for some of the natural language processing, because some of the things we're looking at in free text, we will have in a structured format because we'll have it in the system, the source system. So like the medication, potentially, we need to consider that. So it is something we're considering, but we need to get the data ingested and on board, which we're nearly there, certainly with some of the data from Oxford. We will have access to a wider variety of data sources, including Oxford Health's data sets. We'll be including the PROMS data because we were fortunate to have the True Killers as one of the systems that we will look at onboarding that. And as well as the medication data sets and equally the psychological services. So there'll be multiple data sets to support the mental health. Yes.
Thank you. Can I just go to Brian next, and then Jim will come back to you. So Brian, I suppose one of the questions that academic research colleagues, particularly in the university, will want to know is, well, we're already using data to underpin world-leading research. And of course, the JRO is proud of everything that its partner organisation researchers have achieved and do achieve. So what's the gain? What's the new benefit? How will you, leading this from the university side, communicate effectively to university researchers as to why this is a better way of working with data in future?
Yeah, and I've already mentioned the fact that it will open up possibilities to access data that we, as researchers, may not necessarily have been aware of. One thing that has perhaps not been touched on yet is that, yes, this is a subnational regional SDE, but it is our gateway to data sets from around the country and beyond. And so don't feel as a researcher that you're only going to be able to get access to Thames Valley and Surrey data. Far from it. It goes right across England. And so you need to bear that in mind. I think in terms of communication, I've been doing a lot of effectively a roadshow recently, going around many of the BRC themes, for example, to explain what is coming. And the university is doing a number of things to help you as researchers get access to this and to lower the energy barrier to do so. First of all, the research services team are working very closely with OUH TVS SDE colleagues around how we make sure that you as researchers are properly validated to be allowed to have access to this. We want to make that as easy as possible, but as part of the accreditation for SDEs, we have to do this. Secondly, we are going to be doing a monthly newsletter, which we're going out to everybody. I'll be sending that out to the division and beyond. And there'll also be an FAQ page up on the Medical Sciences Division website coming up. So there's a lot of things going on behind the scenes. There's lots of discussion around the value of data as well, and IP, which many of you may have concerns about. And I would encourage researchers to contact me if you have questions about any of this. Very happy to come and talk to you and explain some of the benefits associated with this.
Great. Thank you, Brian. Jim, you might have had a comment that you wanted to make, but I also wanted to ask you a question as well, which I think you're uniquely placed, which is for researchers to begin using the SDE, will they have to dive straight in and do a real experiment with real data? Or are you going to make available ways of using data sets that are there for testing or piloting?
We could certainly
Do you want to take the mic?
yeah, sure. Answering that, yeah, we can certainly produce a synthetic or dummy data set very easily. But we're not going to belabor that and try and produce something that has the same distribution statistical properties as the source data. Just if you want to see the sort of thing we've got. But you also get a lot of that with the metadata. So going through the catalog, you can see what's the distribution of values in each column. It doesn't, tell you everything you want to know, and we'll have a feasibility service on top of that. But you can certainly have a sense of the data before you start the process of saying, well, I wish to pursue a project in this area. I was just going to say something about the scope in that, so acutes, everything from acutes. And Tanya's point about free text or document, because a lot of the healthcare record exists in free text or document form. That is included. So everything from the acutes, including surgery notes, pathology reports, radiology reports, everything. Clinical letters, discharge summaries, whatever. Ambulance, and then community and mental health. From primary care, we're going for the structured coded data. We're not going for the GP notes in the first instance. And that's just an accommodation that we've made with that community. But that's where we'll be. There's also national data sets in that we want to be the gateway, ideally for university access to the national NHS data sets.
Great, thank you. If you could hand the mic down, because I think there's a question that Kerrie might be able to answer. Well, there's quite a few questions, Kerrie, coming in on cost. Meaning, I think questions about what does it cost to do all of this? What has it cost so far? All the way through to what will it cost researchers to use this really valuable resource? So can you just give a flavour of what it's cost so far? You mentioned that we've been fortunate in getting an highest per capita level of funding to develop where you've got to. How is this going to be sustained financially? And ultimately, can you give an indication of the sort of costs that researchers will need to meet through grants, for example, in order to use the resource?
Sure. So in terms of costs so far, I'm thinking about the money that we've received, which I think is a matter of public record from NHS England. It's about 13 million. Yeah, there you go, 13 mil. Which we've had over about 3.5 years, something like that. It sounds quite a lot, but actually it's been quite a lot to get on and do. That goes from the beginning of business case development all the way through. In terms of what our annual running costs look like, I don't want to get in too much trouble with our CFO, but we have a business case which is approved. The running costs go into the millions, so we need to make sure that we are, as I say, covering those costs before we can even begin to think about value return for ourselves and our partners. Where we are in terms of national network, it's a shame Fred's not here, but I can get him to send some information out separately. There is a national pricing calculator that Fred's actually holding the pen on to develop on behalf of all of the SDE. So the transparency should be there around pricing for researchers moving forwards. There are live conversations with a lot of the big research funders at the moment across the network, which again, I think probably won't distill out until the next financial year, or at least the end of this one, where they are looking to understand quite what this will look and feel like and make sure that that information is reflected in research applications.
Yeah, great, thank you. Brian, please make a comment, and I've got a question for you as well next.
Yeah,
so,
and just to flesh this out a little bit more, I think as a researcher, when you're putting line items into grant applications, it's going to be distilled down into two pots. There's going to be a pot of cost associated with Jim's team, Kerrie's team, extracting the data, going through that bronze, silver, gold approach that they mentioned earlier around getting the data ready and making it available in the SDE. How much that costs will depend upon what data you're interested in and how much that data needs to be wrangled, cleaned, whatever you want to call it. Some people may want just the raw data, in which case it'll be very, very low cost. But if you need it in a particular format, then obviously we as researchers have to find ways to pay for people to do that for us. Then there's the actual cost of doing the research itself. This SDE sits in the Microsoft Azure cloud, and there are costs associated with compute and storage. It's not cost set by the SDE. This is just your standard Azure costs. And again, we would need to put that into grant applications as well. So the answer is, how long is a piece of string? It doesn't help. But this is the reason why you need to sit down with Fred and the team to work through your particular use cases to understand what the costs might be.
Thanks, Brian. So on that point then, this is not a replacement for academic researchers who are big data computational experts. That GPU capability and the data skills that go with it will still need to sit in an academic environment and access data. It's not that it's all just being moved into the SDE.
Technically, it is. But pragmatically, we recognize that there will be use cases, particularly around the AI space, where it is not cost effective to do things in the cloud, where we will have to be able to continue to do things, as we call it, on premise, so within the university. However, what we need to do is to build capabilities within the university to allow us to work in partnership and annex into our local SDE, so that we are able, as researchers, to continue to work with our own data. Perhaps it's multimodal, perhaps it's very large, perhaps it's complex, perhaps it's imaging, where we need and have access to the appropriate GPU, for example, and fast storage. But we need to also make sure that we have direct access to the clinical metadata, which is underpinning some of that other data, so we can do it in an aggregated way. The university at the moment is investing in a trusted research environment. So you remember Jim mentioned that there's a difference between TRE and SD. For the sake of today, it doesn't make a difference, but there will be a TRE that will be made available within the university that will meet, if not exceed, the governance and information governance and compliance expectations that NHS England and DHSC have for SDEs. We'll get it accredited, and that then will allow us to be able to plug into our local SDE and allow our researchers to do the stuff that they're really good at locally where it makes sense.
Great. Thank you very much indeed. We're getting short of time, but if I could ask for very brief answers, maybe Sian, if you'd be willing to take this one. There was a question which I think is important. How, in your comments about engaging with other partners and stakeholders, how has this linked up with established data programs such as Open Safely, Bennett Institute? There are other organizations that have put a lot of time and effort into this. How does this link with those partners and stakeholders, just very briefly?
Okay, so the bit that I can answer on that, I'll give somebody else the answer around this, the Open Safely, which I haven't been involved with. So for the Thames Valley Secure Data, the Thames Valley Shared Care Records Programme, we have worked very closely, I think, since the beginning of the programme, and we now have a joint ethics and engagement advisory board, which has public and professional members. So that is a place where we can go and regularly have debates and ask questions. And we're also just about to hopefully appoint a joint comms and engagement post between the programmes. So those programmes work very closely together. I don't know, somebody else, Bennett Institute and Open Safely.
Just very quickly. So I mentioned that our TRE/SDE approach is eyes on, in that we trust the people involved to the point, I mean, there are legal and technological controls around it, but essentially they're trusted to see a de-identified version of the data, row level, raw, but with the identifiers removed. Open Safely is a very useful option where it's eyes off. So you don't trust the researchers that much. It's not that they're bad people, but you just don't need to give them that degree of access. They send in the questions, you send them the answers. We should certainly bolt that capability on top of what we do. We don't see that as the hard bit. The hard bit is the multimodal data, the free text, the complexity of some of the clinical systems. And just one quick remark about cost. We're spending £50,000 a month getting the data out of some of the clinical systems in OUH alone. We're going to bring that cost down. But the point is the NHS has a lot of clinical systems that it's got a partial data service from. We pay these suppliers. You can get data out one patient at a time or one study at a time for the kind of research that Keith's talking to. Actually, we need it at scale and more accessible with more context. That costs, and we've got to figure out how to make that sustainable.
Thanks, Jim. Very good comment to finish up with. I'm afraid we've run out of time, which we've still got lots of questions we could have asked, which I think illustrates the interest that you've generated. In the 30 seconds we've got left, the important tasks for me are to thank both speakers, Jim and Kerrie, and our 4 excellent panelists who've really brought this to life. It's been a superb discussion and great to have your expert views. Thank you so much. I'm sure all of us would also like to thank Chris Bray and the JRO team who've put so much organisational work into this seminar today. And on that note, we're looking forward to a future seminar in the coming weeks, which will update us and give us an opportunity to hear more about the Berkshire, Oxfordshire and Buckinghamshire Integrated Care Board and how we work with those partners. Please, in closing, if you have any feedback, use the Mentimeter page to let us know any feedback you have on this session. And thank you all, both in the lecture theatre here at the John Radcliffe and also online, for making time in your busy schedules to join this very interesting JRO seminar today. Thank you.